Geriatric. Thank you very much. Good afternoon, ladies and gentlemen. Let me first thank the organizers of this meeting, Nestlé, for the invitation and the possibility to share with you my view on the safety, the efficacy, and the tolerability of NSAIDs, especially in elderly people. Let me start with my conflict of interest statement. And to make something clear, there is no conflict of interest for this presentation. This lecture here is supported as the whole symposium by Nestlé. However, Nestlé has had no influence on the contents of the following presentation. So let's start with some basic information on the frequency of the use of NSAIDs in Europe. This is OECD data comparing the use of NSAIDs in different European countries between 2005 and 2017. And as you can see, there is a significant increase in most of these countries. Overall, in the year 2017, we have an EU projection of 8.5 billion daily defined doses of NSAIDs use. If you compare the development over time, you can see there are countries like Estonia where there's a significant increase. There are some countries with a decrease, and if we focus here a little bit on Germany, there is an increase between 2005 to 2017 of 11% of prescriptions or use of NSAIDs. So this is the NSAID market in Germany in 2021. As you can see, the majority, more than 50%, is due to the prescription of non-aspirin, non-selective NSAIDs. Roughly 150 million DDDs are to the prescription of COX-2 inhibitors, and further 430 million DDDs for the use of OTC NSAIDs. And these are the components that are most frequently used in our country. And you can see there is a significant problem we already have if you focus to the talk of Yves that he gave us earlier on. So what is the definition of an NSAID? NSAIDs are a very heterogeneous group of different molecules. They can be grouped according to their COX sensitivity and COX selectivity because most of these components exert their activity, as you all know, via the inhibition of the cyclooxygenase enzymes. So we differentiate between COX-1 inhibitors, non-selective NSAIDs, the older COX-2 inhibitors, and especially the so-called newer COX-2 inhibitors. And all do the same, more or less. They inhibit the transformation of arachidonic acid into PGG2 and PGH2. And this transformation is usually mediated via one enzyme that's called the cyclooxygenase enzyme. And the one that has detected this transformation mechanism was John Wayne in his publication in 1971 in Nature New Biology. And in 1982, he was awarded the Nobel Prize of Medicine for this detection. So now we know that there is not only one enzyme, there are two enzymes that are responsible for this transformation. And according to their selectivity, the different NSAIDs act on different enzyme subgroups. The COX-1 inhibitors preferentially to COX-1, and the COX-2 inhibitors preferentially to COX-2, and the non-selective NSAIDs to both enzymes, and the older COX-2 inhibitors a little bit more on COX-2 instead of COX-1. And by doing so, they are able to reduce inflammation and fever and pain, if pain is related to inflammation and fever as well. Well, Wayne detected the mechanism in 1971, but the first medical description of the effects of these anti-inflammatory products goes back down to the 70s of our time projection. This is Dioscorides. Dioscorides is a Roman physician that traveled with a Roman soldier through the world, detecting and evaluating nature medicine, phytomedicine, and how it can be used to increase the tactical advantages of the Roman soldiers. And until the 15th century, his observations and his evaluations of the phytotherapeutic approach, here written down in the so-called Dioscorides, influenced significantly the medicine in Central Europe. So what we now know is that COX-1 is responsible for a significant number of physiological processes in our body, and COX-2 for another group of physiological processes. As you can see here in the middle of this presentation, there is a significant number of processes that needs the interactions, the physiological coactivity of both enzymes. And the situation becomes even more complex if you see that we need COX-1 activity for the mucosal protection of the GI tract, but we need COX-2 activity for the mucosal integrity of the GI tract. So it's not the easy answer if you have a patient suffering from GI problems, use a COX-2 inhibitor, because if this patient already suffers from a GI mucosal damage problem, the use of the COX-2 inhibitor will prevent the healing process. So it's a rather complex issue. If you focus on fever and inflammation, what is a necessary approach if you want to treat patients with osteoarthritis, you can see that the COX-2 activity is essential. Here's a comparison, 7-day activity of a COX-1 inhibitor or preferential unselective COX inhibitor like diclofenac compared to celecoxib, which is one of the so-called newer COX-2 selective components. And as you can see, in comparison to placebo, both are significantly better. No differentiation between the active components, and the same is true here if we compare the activity with placebo on other further activities. So this has all been reported by Dioscorides nearly 2,000 years ago. But Dioscorides also reported some other problems he observed while treating patients with willow bark extracts. And he reported bleeding time increases, and that's a COX-1 activity. If you support and if you give a drug to a patient that is a COX-1 active component, you interfere with the thrombocytic aggregations or the platelet aggregation function. This is a placebo group here, and if you give a selective COX-1 active component like aspirin, you can see that the platelet aggregation within 2 hours after administration of this component decreased dramatically. And due to the fact that acetylsalicylic acid acts as an irreversible inhibitor of COX-1, this effect continues for the next 7 to 14 days. But the same is true if you use a competitive inhibitor of COX-1, such in our case here, diclofenac. Even after a single dose of diclofenac, the platelet aggregation decreased significantly, but restored within 5 to 6 to 8 hours. The same is true for ibuprofen. And if you continue a treatment, and you all know that it's necessary to use these components repetitively several times per day, you can imagine that the platelet function of our patients goes down, goes up, goes down, goes up, goes down, goes up. This is shown here on the right side of this picture for day 8 of the treatment. You see some kind of habituation effect, but that's not really a critical issue. The thrombocytic function in our patients treated with these components is significantly impaired. Another thing Dioscorides reported was abdominal pain and gastritis, or we would call it gastritis today, and GI bleeding. And the combination of gastritis and a disturbed bleeding function, clotting function, with a GI bleeding is a significant and life-threatening combination. The upper slide here is a picture of the mucosal surface of what is called acute erosive gastritis as a consequence of 1,000 milligrams ASS single dose. Usually the thing you take after a long evening, 2 or 3 bottles of wine or whatsoever in the morning. So this is like your GI tract, especially the mucosa in your stomach, looks like 2 hours after the use of aspirin in everybody of us. It's a transient change of the mucosal behavior. The lower picture here is a chronic gastritis consequence of intermittent use of ibuprofen, here 400 to 800 milligrams 3 times daily for 8 weeks. And the situation becomes even worse if the influence of the NSAIDs on the mucosal integrity continues. This is a preparation of a patient who did not survive the treatment. And what Dioscorides also reported to us was GI ulceration and death in response to the treatment he developed out of willow bark. These GI ulcerations due to the mucosal surface, and unfortunately, if these ulcerations hit a GI artery, then you have an acute arterial bleeding in these patients. And this is a life-threatening condition even for young, healthy people who experience this complication in an emergency department in a hospital here in London or wherever. This is what we call an ulcus de la Foy. You see the ulceration here. This is the opening of the artery that is supporting the gastric stomach with blood. And this is a patient who did not survive this arterial bleeding. And unfortunately, the experience of an acute arterial bleeding out of the stomach due to an NSAID-related GI ulceration is indeed not a nice thing, and death is not nice as well. These patients don't survive usually. They They die because due to the aspiration of their own blood, usually in the evening, in the night, and usually elderly ones are affected. And these are the typical finding situation of these patients: blood everywhere, in the bed, in the walls, whatsoever. And this is a situation where policemen and others came and evaluate really the case. In all these cases here, the responsible drug is an NSAID. In this case here, diclofenac, 50 milligrams given 3 times daily. This is also a patient that presented to us. Ibuprofen, 600 milligrams 3 times daily. You can see the peritonitis due to the bile and the ulceration of the duodenal ulcer. And the critical thing is that this is an inflammatory-related pain, and unfortunately, NSAIDs are potent inflammatory inhibitors. So the situation is you suffer from a critical life-threatening problem, but you aren't aware of that. And this is nicely shown here by data from several years ago. Paris Goodman and colleagues reported that the hospitalization rates of elderly people in response to a GI tract problem increased significantly if they have a treatment with NSAIDs, shown here, or not. And the very critical thing is that only 1 in 5 of them realize that there is something going wrong in his body. So only 1 in 5, 4 in 5 develop a significant life-threatening condition, but they have no idea about that, no warning signals, nothing else. So that's a critical problem, especially for elderly people. So in the pre-COX-2 inhibitor era, NSAID-related death was the 3rd most frequent death in the United States, with 16,500 patients dying per year per 10,000 people. So there's a lot of evidence for that, and all this evidence shows that selective or non-selective COX-1 inhibitors are responsible for that. And there are some critical risk factors in addition to that. So history of ulcer is critical. Treatment duration is critical, but as you can see here, even a short-term treatment up to 30 days led to a significantly increased risk for the development of a life-threatening or severe GI tract problem. And the dose is a critical problem. The higher the dose, the higher the risk. The combination with low-dose aspirin is a critical issue. The age is a critical issue. With increasing age, the risk increased as well. And especially in those elder than 70 years, we have a significant problem. Females are a little bit more prevalently affected than males, and there are significant interactions with comorbidities like heart failure, diabetes, or alcohol use, and a co-association with co-medications such as SSRIs or warfarin, but not apixaban. As a reaction to prevent these NSAID side effects, we usually prescribe some protective agents like PPIs. So this is the prescription rate of PPIs in Germany per year, 3.7 billion DDDs. It's crazy. Roughly 50 to 60% of those prescriptions are especially to prevent NSAID-related complications. But the problem is these PPI prescriptions have an own risk and carry a significant own risk for the health of our patients. This is shown here in a patient I saw her a few years ago together with my students in the internal emergency department. A female, 75 years, who presented to us with some signs of cardiac problems developing over 3 months. You can see fatigue, weakness, irregular heartbeats, shortness of breath, dizziness, chest pain, cold hands. She presented with some pale and yellowish skin, and she got a treatment for her osteoarthritis of the knee with ibuprofen, 600 milligrams 3 times daily, plus a PPI, in our case the omeprazole, 10 milligrams twice daily. And this was her hand. And this was the hand of her husband. And we've done some evaluation on her and found she suffered from a severe hypochromic anemia. So this is the erythrocyte count, the hemoglobin scores you show here, MCV, MCH, the reticulocyte count, ferritin, transferrin. So these are the red cells here. Usually these are red cells, but there is no red color within these cells due to the blood loss over months. The question is, where did this patient lost her blood? And we made some gastric evaluation with a radioscopic technique, and what we found in her small intestine were these uncountable mucosal lesions. And these mucosal lesions are well described, or in the literature, it's chronic lower GI tract bleeding, as a response of an intestinal dysbiosis as a consequence of the treatment with proton pump inhibitors. And this is a picture of a preparation and a presentation published 2011 in Gastroenterology, where you can see the same lesions, but not in male, but in rats. And what we now know that if we provide a PPI to the patients, we are perfectly able to reduce the acid secretion in the stomach, shown here. But unfortunately, the number of mucosal lesions in the small intestine increased with an increasing decrease of the proton secretion of the GI tract. So the issue is, what are we doing here? And if we compare the different patient populations over time, we see that with PPIs, we are able to reduce the upper GI tract drug-related adverse events, but unfortunately, we significantly increase the lower tract GI problems, and the number of the increase, or the increase is higher than the decrease. And these lower GI tract drug-related adverse events led to a significantly more frequent hospitalizations and a significant increase in the mortality rate in affected patients. So it's not necessarily a good idea to treat a complication of an NSAID with a long-term treatment with a PPI. So this was our understanding until 2004, and everything was fine so far. But in 2004, there were various things happened. One thing was that we found evidence that COX has something to do with renal dysfunction. Several very important publications came out, and we realized that COX-2 inhibition is something that interferes with renal function, leading to a renin release decrease, renal blood flow decrease, glomerular filtration rate decrease, ADH secretion increase, and whatsoever. So it seems also, not only from a GI tract perspective, but also from a renal perspective, not really a good idea to treat patients with NSAIDs, at least for a longer time. And then the first reports occurred on heart insufficiency, myocardial infarction, thromboembolic complications, and even death. And this was the pivotal publication in 2005 on a trial, the approved trial, where a selective COX-2 inhibitor, rofecoxib, has been given to patients over a period of 3 years in a randomized double-blind fashion versus placebo in patients carrying a significant risk to develop adenoma colorectal cancer. And the question was, are we able to prevent this progression of these mucosal changes into a cancer disease? And rofecoxib worked quite well, but unfortunately, shown here, after 18 months of treatment, both treatment groups separated significantly with respect to the number of confirmed thrombotic events. So after 18 months of continuous treatment with 25 milligrams of rofecoxib, there was a significant increase in this complication rate versus placebo, and this was the reason why this component has been, within months, taken worldwide from the market. Well, everything is clear. COX-1 inhibitors have a problem, but COX-2 inhibitors have a significantly more severe problem, and now we are fine because we don't want to use COX-2 inhibitors. But unfortunately, 2 years before this publication here, in the same journal, the New England Journal of Medicine, this trial has been published. A randomized trial of aspirin to prevent colorectal adenomas. Same design, 3-year treatment versus placebo, but now low-dose aspirin, 85 milligrams and 325 milligrams versus placebo, to see if it is possible to prevent the occurrence of colorectal adenoma. And the risk of patients developing myocardial infarction, stroke, or other critical thromboembolic events in this trial was 7 times higher with ASS versus placebo. Not 2 times higher as with rofecoxib, but 7 times higher. And the risk difference is 5, and the risk with ASS is 3.6 times higher as the risk with rofecoxib. And I'm not sure what happens here in your nice town in London, but when I left Frankfurt yesterday, aspirin was available in our German pharmacies. The question is why? It's a significant risk drug, increasing significantly the risk of patients with that component. And the reason why it is still available is because nobody knows why this happens, or nobody is interested in why this happens. That's a big issue. So what happens? The interaction with the transformation of acetylsalicylic acid into PGA-G2 and PGH2 is not the end of the story. because PGH2 has a half-life of seconds depending on the different tissues and is then by itself changed into different other types of prostaglandins. And dependent on the tissue and the prostaglandins that is produced, different individual safety profile result. And this looks like that. So it's extremely complex. And in some cases, it's beneficial to inhibit this progression, and in some cases, it's not. And unfortunately, sometimes COX-1 inhibition is good, and sometimes COX-1 inhibition is bad. And the same is true for COX-2. As you can see, the inhibition of COX-1 in platelets is not such a good idea, but the inhibition of COX-1 and COX-2 in endothelial cells is beneficial, and the inhibition of both is beneficial as well if they are especially treated smooth muscle cells, and it's bad if you treat macrophages and whatsoever. Unfortunately, these drugs don't differentiate what kind of COX they actually inhibit. If you use it, if you swallow it, they inhibit every COX that is available and reachable by them in the metabolism. So the bad news is it's not a problem of the component, it's a problem of the patient. The patient decides if he's one that develops side effects or beneficial aspects in response to a treatment. We usually thought it's an easygoing treatment. We are able to make some risk-benefit optimization processes. And the best thing is to think about the pathophysiology of pain. If a patient suffers from an inflammatory type of pain, well, I think it's for the first few a good idea to give an anti-inflammatory component. But that's the first thing we have to decide. Is it really inflammation in that patient? In osteoarthritis, in the flare, frequently it's inflammation, but the question is it necessary to treat it with an NSAID? But in many, many other painful conditions, inflammation plays no significant role. But nevertheless, NSAIDs are the treatments of first choice. And I think that's not a good idea. But if inflammation is responsible for the pain, we should treat it with some adequate anti-inflammatory agent. And if we now focus a little bit on individualization of the treatment, we can develop and find some clinical risk factors. So age is a significant clinical risk factors, in patients with an age of 65 years or even older carry a significant risk of developing these complications within days, not weeks or months. Comorbidity with general diseases, a history of GI tract problems is a critical issue here, hypertension, cardiovascular diseases, and renal diseases as well. And beyond that, we have a group of pharmacological risk factors, so the dose and the longer half-life of NSAIDs is a critical issue, the treatment duration for sure, and the co-medication with glucocorticoids, low-dose aspirin, anticoagulants, SSRI, and antihypertensive drugs. So if we focus a little bit on the recommendations for the treatment of OR, Yves has shown something on that. I aggregated several other recommendations here in the different treatments, pharmacological treatments, more or less recommended to treat. And if we focus on that, the most prevalently recommended treatment over all these different guidelines are NSAIDs. And more or less NSAIDs oral and versus topical NSAIDs comparable, as you can see, and Yves reported to us, topical NSAIDs is the preferred ones in the ORC, but not in every other guideline here. You can see alternatives are recommended. Well, tramadol is a representative of the group of opioid analgesics and other opioids as well. But the question is, how do they work if inflammation is the problem of our patients? These are not medications and analgesics that work via an anti-inflammatory process. And there's a very nice meta-analysis that compares the efficacy versus the tolerability and safety of these different groups of recommended treatments in patients suffering from osteoarthritis. And what you see here is an aggregate of all the information out of this meta-analysis. It's a very complex picture, I know, but I like this picture, and I will share with you the main information on that. Here on the x-axis, you see the effect size of the different treatment components with respect to the reduction of pain intensity. And on the y-axis here, you see the odds ratio with respect to the drug-related adverse event treatment discontinuations. So as you can see, most of these components are here in the upper left quadrant. So that means they are significantly, or more or less significantly, better active against pain, but they have an increased discontinuation rate in comparison to placebo. If we now focus a little bit on the efficacy side here, the bottom of the picture, we can see that NSAIDs, oral NSAID, are the most effective components in these aggregated data of randomized controlled trials, whereas perfect effect size differences from NSAIDs in comparison to paracetamol, opioid analgesics, and especially to placebo as well. Then followed by topical NSAIDs, then followed by opioid analgesics, paracetamol, and this is a placebo activity. Within the group of the oral NSAIDs, etoricoxib is the best one, followed by diclofenac and naproxenoside. And these components in these dosages given here share a more than 90% probability that a patient reports an improvement in his symptoms that is more than what he expected and what is necessary to improve his daily life. These minimal important difference. Here, with the topical treatments, we found that diclofenac is the best component. Dosages are given here, and once again, the MID probability is above 90%. For paracetamol, the probability of a patient that he really reports an improvement in the symptoms of 20% or more for 3,000 milligrams. And for the opioids, it's tramadol in combination with paracetamol, buprenorphine, sublingual and transdermal, oxymorphone, and tapentadol. And the probability that is a significant, individually relevant improvement is 40% for these components. Opioids. So I'm a pain specialist, and as you know, pain specialists like opioids because opioids have no organ toxic side effects. That's what we usually talk to everybody. That's true, but that's only true if you take the brain out of your calculation. For most pain specialists, the brain is not an organ. It's some kind of biomechanical activity device or whatsoever. But unfortunately, if you take the brain into your calculation, opioids have a significant risk of organ toxicity. This is nicely shown here in this large study from Solomon published several years ago, where he compared the safety of opioids versus other components in older patients with arthritis. And the bad news for our pain specialists is that the mortality rate related to opioids is significantly higher in these OA patients in comparison to NSAIDs, 1.9 times higher, the hazard risk here. And here are several calculations of individual risk. The cardiovascular risk is higher with opioids. The composite fracture risk is higher with opioids. The related hospitalizations is higher, and the all-cause mortality is higher with opioids. So opioids interfere with the brain, not with the renal system or with a little bit with the cardiovascular system, but especially with the brain. And these faults and these fractures are significant risk factors for our patients. So the question is, what do we now do? What if we had a drug that shows that profile here, that is located here in the lower left side quadrant, showed a drug-related adverse related discontinuation rate comparable to placebo or better, shows an efficacy rate comparable to NSAIDs or better, but there is no NSAID. And that's an oral enzyme combination. And this is data from this double-blind randomized placebo-controlled trial comparing this oral enzyme combination versus placebo in patients suffering from knee osteoarthritis. And as you can see, there is an alternative to NSAIDs, and even there is an alternative to NSAIDs that acts as an anti-inflammatory component. And there's another study randomized controlled on these oral enzyme combination. In this trial, you can see a comparison versus diclofenac, and there's a significant superior, better pain and symptom relief associated with the oral enzyme combination in a significant number of patients, more than 1,400 patients, in comparison to NSAIDs, and the tolerability is significantly better. And as you look here on the safety profile, first column group are drug-related adverse events, 27% with NSAIDs, 3.8% with OEC, and more than 2 DREs, GI-related DREs. So it's a very nice component, and the question is, why don't we use it more? The question is because we don't know really what is OEC, what is an oral enzyme combination. Well, it's a complex mixture of 3 proteolytic enzymes in this special case here, containing bromelain, trypsin, and rutin. And our very superficial hypothesis how this might work is that this enzyme complex interferes with free alpha-2 macroglobulins, and the binding of these enzyme complex led to a change of the molecular structure of these alpha-2 macroglobulins, and then activation of these macroglobulins, and then an exposure of these cytokine binding sites here in the middle of these molecules. And at these binding sites, these activated macroglobulins are able to bind and to irreversibly bind pro-inflammatory cytokines, far beyond PGE. So all these cytokines we've heard and learned about by the talk of Eve. And they are irreversibly bound, though they go the natural way of all these macroglobulins and are eliminated out of the pathophysiological process. So when we learned about that component, we started a meta-analysis of all available data. We contacted the company that was responsible for that component in Germany at that time point and asked them, please give us the whole data, the original data, the raw data of all randomized control trials we ever had made and performed for this component. And we found 6 randomized controlled trials for patients with osteoarthritis of the knee and comparisons versus diclofenac, and we started a complete reanalysis of all the data we had. And as you can see, overall, we found data on 774 patients. And just look here at the daily dosages compared. The dosages of diclofenac 150 or 100 milligrams per day have a treatment duration of up to 12 weeks. So this is indeed a very, very effective dose of diclofenac in comparison to 3 times 2 tablets of the OEC component. That's nice. And what we found that OEC was comparable effective as diclofenac. You see the improvement rate, 75% with OEC, 77, 78% with diclofenac. If we directly compare the response rates, you can see in the regression analysis, no difference, virtually no difference between both components. And you see the baseline situation was absolutely comparable. The end of treatment situation over 3 up to 12 weeks was absolutely comparable. So it was effective as a high potency, high dose NSAID. And what you can see as well is that with an increasing severity of the disease, here measured with the Lecain Alco Functional Index, the efficacy of OEC increased as well. So this is not only a component for those patients suffering from minor problems, it works in severe problems as well, and even better than in other patients. And this is nothing that is normal. If you compare this data here for OEC and compare it with the placebo data out of the Bolton trial, you can see that patients that are treated with placebo behave the other way. They worsen during the clinical trial, while patients treated with the OEC component improve during the clinical trial. So that's not a spontaneous reaction. This is really indeed the reaction to the pharmacological activity of the oral enzyme combination. In comparison to diclofenac, pain at rest and pain on movement is absolutely identical, either if you focus on the minimal clinically important difference or on the improvement of 30 or 50% versus baseline. It's very nice. But the difference was here on the safety and tolerability side of the medal. And as you can see, once again, the number of drug-related adverse events was significantly less with OEC in comparison to diclofenac. The number of patients that reported any drug-related adverse events was significantly lower with OEC. Patients with drug-related adverse events of the GI tract was significantly lower, and patients that discontinued treatment was significantly lower. And we had in this group here with diclofenac 6 patients who reported a heart issue during the treatment. And diclofenac is one of the components out of the NSAIDs that carries a significant cardiovascular problem for elderly patients. What is even more important is this figure here. These are data on the laboratory control between baseline and end of study. What you see here is an aggregate of patients that presented with any kind of worsening of their individual laboratory scores. So you can see there is at the bottom line here, a change in response to OEC between 2017, 18, 28, 26, 30%. It's the normal fluctuation if you, on an ongoing way, make some laboratory analysis here on the left side on the red blood count or here on liver enzymes. But what you see as well is that the number of patients that presented with these changes with diclofenac is significantly higher. And we then went back to the Bolton study and focused what is the response to placebo. And as you can see, what we saw with OEC is what we absolutely see with placebo in the Bolton trial. The OEC does nothing with respect to these laboratory parameters, with respect to any organ toxic issues that were evaluated here, while NSAIDs carry a significant risk problem. And the last word on this trial here, Singer published in 2001, not the latest study for sure, a 3-week treatment evaluation with an ongoing open observation without treatment. And what we see here on the left side is OEC response, a significant decrease of all these different scores evaluated. The same is true for diclofenac here on the right side. But after we stopped the treatment, after 21 days, you see a different behavior of the patients. While those patients initially treated with OEC improved further, patients initially treated with diclofenac worsened in all scores. The question is what happened here. So we saw these further improvement, the first 3 weeks were treated with OEC in comparison to a significant deterioration of the effects achieved with a 3-week treatment with diclofenac. And it might be a difference in the aspect of how these anti-inflammatory response has been produced. This is some signal for an OA progression, so this is a purely symptomatic treatment, while we saw with OEC some kind of, let's say, disease modification, some beneficial effect, going on, further extending over the next weeks, even after the treatment stopped. And we saw some very new papers, Eve already reported about it, that NSAIDs are effectively symptomatically relieving pain, but they do nothing for stopping the progression of osteoarthritis. Even more, they increase, obviously, the progression of the osteoarthritis shown here in this paper, published in 2021. And another paper just recently has been published by this study group here, and they reported as well. People with osteoarthritis that have been treated with NSAIDs have a greater risk of radiographic osteoarthritis progression in comparison to those without. The same we now know is true for low back pain patients, back pain patients with the use of NSAIDs. So that's a big problem, and the story is not told until the end. So NSAIDs, still the current gold standard in treatment recommendations, carry a significant risk of side effects, especially in elder people, and that's a big issue. Conventional analgesics such as paracetamol or opioids are not a good answer. They symptomatic pain relievers with a significant group of side effects, paracetamol, liver toxicity, opioids, death, and whatsoever I've shown to you. The answer is an oral enzyme combination the answer to everything? Well, for sure not, but for the majority of patients, for sure yes. Thank you for your attention.